This one question that I recall just from the email, I can just sort of start if you don't mind. We There was a question about hypertrophic cardiomyopathy, I think, in the association in the setting of Barth syndrome, and so this is just a slide that lists what we consider the sort of five phenotypic cardiomyopathies. Dilated cardiomyopathy is one that we see very frequently in both kids and adults with and without Barth syndrome. And this is most traditional cause in the United States of sort of this dilated phenotype would be ischemic disease or coronary artery-based etiology. But we also see dilated in people who have genetic triggered heart muscle disease as well, and then the other four are really felt to be very strongly genetically triggered. So hypertrophic cardiomyopathy in all cases is a genetically triggered disease. Restrictive cardiomyopathy and arrhythmogenic cardiomyopathy we don't really see in the setting of Barth syndrome, so I won't belabor that. And then at the last, obviously all are very familiar with left ventricular non-compaction. The question, I believe that it was posed via email, was about hypertrophic cardiomyopathy. Has that been seen in Barth syndrome? And it definitely has. And then, can those phenotypes sort of change? I think, people hear the term hypertrophic cardiomyopathy, and it's most commonly associated with people experiencing sudden death with activity. So people like athletes, for example, this is one that makes the papers or will be of tremendous concern to people. But the thing about hypertrophic cardiomyopathy is it doesn't always stay hypertrophic, and all we mean by hypertrophic cardiomyopathy is just that the heart muscle is thick. Sometimes about 10% of cases of hypertrophic cardiomyopathy actually can change into a dilated cardiomyopathy phenotype, and that's what's called a burned out hypertroph. And all it means is that these hypertrophic cardiomyopathy patients develop scar tissue in the heart muscle, and that scar actually ends up replacing the heart muscle itself. And the scar is typically tighter and a little bit thinner than typical cardiomyocytes, which in hypertrophic cardiomyopathy are big or hypertrophy. And so you can actually go from a thick heart that squeezes in a supranormal fashion to a thinned out heart that's dilated and doesn't squeeze very well. And like I said, that happens in a few patients, and the management's very different. We have lots of medical therapies for hypertrophic or for dilated cardiomyopathy. We don't have huge amounts of therapies for hypertrophic cardiomyopathy. Most of those are directed at mitigating symptoms. So they are very different diseases, and the management is very different, but that can definitely happen. But I think one question, if I recall, was about hypertrophic cardiomyopathy in Barth and why Barth is not on hypertrophic panels, if I remember correctly, which is a very thoughtful question, actually.
That's correct.
When you think about panels that are created for hypertrophic cardiomyopathy, they're somewhat small. They're getting more robust, but they're probably in the neighborhood of about 24 to 30 genes for most commercial companies. And the reason that they only are constituted by a certain number of genes is that it's really about catchment and about cost. So there are lots of different genes that have been associated with hypertrophic cardiomyopathy, the majority of which are sarcomeric. But for example, another genetic-based disorder that's syndromic in nature is Noonan syndrome. Noonan can present with hypertrophic cardiomyopathy as well. Many companies don't have Noonan-specific genes on their panels either. They're becoming a little more commonplace. I consult with these people, and some other folks do, that we've actually advocated for these sorts of things, is that maybe expanding these panels makes sense. I think some of the reasons that they would not include any Barth-based kind of testing is just because of the numbers, and the frequency is going to be so low. And the other point of this is that people need to recognize that in the current era, most of what we do for genetic testing is based on a small profile. So let's say we're looking for something like left ventricular non-compaction, and we develop a list of genes that we think are responsible for LVNC. And let's, to say for argument's sake, that's 30 genes. Well, we're talking, you know, the cost of that is not insignificant, as many of you all know when you research medical-based testing and genetic testing. The gap between the ability to do 30 genes and to do whole exome sequencing, so to look at every gene, which is somewhere around 25,000 genes, the cost is getting very close to where, as opposed to doing 30 genes, you can do 25,000 genes for maybe a few $100 difference. And so many companies are appreciating the idea of doing dedicated testing for a particular disease that only captures a handful of genes is probably going to fall by the wayside. That's really not keeping up with the sort of the leaps and bounds that are being seen in genetic testing and genomic testing. The shift is that you'll get all of the information for essentially the same cost. The problem that is for any of you that have been involved with genetic testing or seeing these results is that they're not always black and white. Sometimes you'll have data that are very conclusive and you see a mutation or it's known pathogenic sort of relationship to a phenotype. And then other times you'll get what are called variants or variants of unknown significance, where you get a mutation that you think is probably deleterious based on modeling data or on animal data, but no one's ever reported it in humans. And so that becomes a bit of an issue, and that happens even when we do testing on 5 genes. When you start doing testing on 25,000 genes, you get a whole lot of these different sort of potentially causative mutations that most of the time is being just run through a fancy computer and saying, okay, we're going to try and predict what the protein product is of this mutation is, and some of them are easy. If it's a truncating mutation where there's no protein made, you know that that's likely deleterious. If it's a mutation that results in a protein that maybe has some abnormal function, that's where things become a little more challenging. So genetic testing, ultimately, when we start doing, and we've started doing this in our own cardiomyopathy population, is that we do pursue whole exome sequencing in some patients where we're not just getting that few handful of genes, we actually get them all. And so, but the flip of that is that sometimes you get reams and reams of data and you're not exactly for sure how to interpret it, and it requires a very high level group of individuals to help you to make sense of those data. So, but it was a very good question, I thought. If I remember it correctly, it was very good.
Yeah, that was exactly.
What else can I answer, Shelley?
The other question, I guess, to your point, there's a couple of things. One was, are hearts evaluated by pathology after being explanted? And if so,
yeah,
do you find non-compaction in the right ventricles as well?
Wow, good question. So just from performing autopsies for children that are in the hospital, oftentimes that's up to the family. Is that something that we want to pursue? And we don't always do that. For children that would pass outside of the hospital, sometimes that would be, depending on the area of the country, that they may actually require some sort of a post-mortem analysis. You can imagine that that's a unique opportunity because we actually get to do testing that otherwise we can't do on live patients, where you can actually look under a microscope and do fancy kind of histological testing and do some of the biomarker testing that Dr. Hybe was referring to. The idea of the right ventricle being non-compacted is a good one. We see lots of non-compaction, and so in our experience, you can, it's very rare that we would say someone has isolated right ventricular non-compaction, but we do see it in the setting of biventricular disease. So someone who has left ventricular non-compaction but also has a heavily trabeculated right ventricle. So just for everyone's understanding, the right ventricle is normally trabeculated. So anyone on the conference that got an echo or an MRI, it should be trabeculated. The question is how much is beyond normal, and that's when we talk about RV hypertrabeculation. We have our own thoughts about how that looks on an echo or on an MRI, so it wouldn't require any kind of a post-mortem analysis. We feel comfortable actually calling it on imaging studies. The number of patients that we have with true biventricular disease is very, very small, and we probably follow one of the largest cohorts in the world of non-compaction patients, including, obviously Barth's going to be part of that substrate. But in our opinion, those patients maybe have a little higher risk for arrhythmias and unusual potential for sudden death or sudden arrest. And so we actually treat them a little more conservatively than some of our patients that have isolated left ventricular non-compaction. So the entity does exist. It takes I think someone who's used to looking at the disease and someone who's used to looking at imaging studies to call hypertrabeculation of the right ventricle, because like I say, it's a normal finding. Everyone should have a trabeculated right ventricle. But there does come a point in our mind, and it's sort of a shade of gray. It's not like an absolute point, but where there's just too much. And I can, if anyone's interested, I can give you more specific echo or MR criteria that might provide some insight into that.
Okay, thank you. What's our time? Do you have a hard stop in 3 minutes?
Yeah, but like I said, hopefully most of y'all have my email already, but if you don't, you're more than welcome to email me at any time, and I'll try and give you the knowledge that I have.
I have one question, I think, from the ones that I sent to you.
Okay.
And maybe we can elaborate a bit by email, and then we have a mom who has forwarded an email, but I want to get to the questions that were posed first. One of the things that one of the moms, and I'm just going to paraphrase the question, is the child received a transplant, and the question is that now that my son has had a transplant, when a treatment becomes available, how is this going to affect him? Is he going to benefit from any therapies that are developed for Barth syndrome?
Oh, I see.
So I think, is it just going to be targeted to heart, even though he has Barth syndrome, or is it going to help his heart? His heart doesn't have Barth syndrome.
Right. That's a good question. Yeah, transplant hearts have the DNA of the donor, right? So the genetic milieu of that transplanted heart is going to be from whomever it came from. And so therapies that are targeted at Barth syndrome specifically probably won't have any positive effects on the transplant heart, but they don't need to, right? The problems with transplants are a little bit different in nature, and those come back to acute and chronic rejection and the development of coronary allograft vasculopathy and some other things that predict the longevity of the graft. But the big thing is that we would want to make sure in any study that's human subject related is they're not having any deleterious effects or any untoward effects. And cardiac surveillance is always a part of drug investigation. And so we don't think that there would be, likely be any beneficial effects, but that's okay. The thing we want to make sure is that there are no untoward effects or ill-intended effects. We would say, as with a lot of therapies we deal with, that any patients have any kind of neuromuscular-based disease or skeletal muscle-based disease, is that many of those therapeutics are targeted at skeletal muscle function. And sometimes it's a complex milieu, but at the end of the day, it may help with overall cardiac function. It may help with graft longevity. So I don't think that any new therapies like the fibrates we've been discussing, they may help a little bit from a coronary artery disease perspective in a transplant, because we do put those patients on statins, for example. But the main thing is that it might have that opportunity to help with neutropenia, it may have that opportunity to help with skeletal muscle function. And in which case, from a cardiology perspective, I would be hugely supportive of doing those things. The transplant heart, we expect those grafts to work well, so I'm not really looking for a therapy to try and make it work any better than what it will.
Thank you for that. I have a question from Michaela Demin, and I think after that you're going to have to scoot, and
okay,
maybe we can get you back for these other questions.
Yeah. No, seriously, you guys can email at any time. I apologize for having to run. It's just been kind of a crazy weekend for me.
That's fine. Michaela, you're unmuted if you'd like to ask Dr. Jefferies your question.
Hi, Dr. Jefferies. I'll be very quick. I just wanted to ask you how quickly you think our families will be exposed to new drugs. I was just reading about Novartis's new LCZ696 drug.
Right.
And those sort of drugs, and then, how do we as a group, how long would we typically wait before our boys are treated with drugs that are showing good effects?
Well, amazing question. You must be looking at my calendar. So I was just in New York meeting with Novartis about LCZ. So so LCZ is almost ready for FDA approval in the United States for adult heart failure. So they're very large data sets, and it's sort of a game-changing kind of a therapy. And there is a large study called Paradigm that was published in the New England Journal about LCZ696, which actually has a trade name now, but I think LCZ is what most people refer it. But the new drug's name is called Entresto. So the reason I was meeting with them was about they want to do a pediatric plan of investigation, and they specifically want to enroll patients to see. There'll be two arms. One is potentially about developing pharmacokinetic data, which we have to do for all dosing, right? We don't know what the right dose is for kids as opposed to adults. And then a larger study looking for efficacy, just as you heard from Dr. Hybe. So the idea of an endpoint, whether that's an ambulatory endpoint or whether that's something else, and then patient-reported data. And so interestingly enough, it's entirely possible that access to LCZ may be something that could happen in the United States in the beginning of 2016.
Oh, wow. Okay.
Yeah, it would be under trial investigation, obviously. But they were asking about which populations, and when we talk about pediatric patients with cardiomyopathy and heart failure, that's a broad range of individuals. It could be from a various and very heterogeneous substrate. But so Barth, depending on what the FDA tells us the inclusion and exclusion criteria will be, it's possible that that could be part of the milieu, just as Duchenne, for example, could be. We don't know for sure, but I can tell you that there's a very aggressive plan to have LCZ approved in the United States for commercial use. So it's a very exciting opportunity. Something we don't usually get to do is that oftentimes the therapies we use in our kids, regardless of the cause of their disease, is what we would say is off-label, right? That there are no evidence to support the use of ACE inhibitors or beta blockers or any of these sorts of things. But we use them because we feel strongly that they work. Now the requirements in the United States have changed where the FDA mandates that people have these sorts of studies in place and that there are data behind these sorts of studies. So now you can actually get an FDA-approved drug for a pediatric patient that has dilated cardiomyopathy, for example. And LCZ will actually be one of the first drugs to actually undergo that sort of rigorous review. Novartis feels very strongly that the drug will make a huge difference and will save lives. And in the adult world, for example, we traditionally use ACE inhibitors, which we do in our kids as well. The drug was compared, so LCZ was compared to ACE inhibition. And there's a statistic that we use sometimes called a number needed to treat. So how many patients would you need to treat with the therapy to save a life? And it was basically for about every 30 patients that you treated, a life was saved compared to ACE inhibition. And that's a pretty dramatic number when you think about how many people in the United States and worldwide live with heart failure. So they're very invested in making it work, and myself and a few other investigators from around the country are very excited about the idea of something new that we can actually do to make a difference and avoid transplant. At the end of the day, that's what we're trying to do. And,
yes, it's very exciting, isn't it?
I
just wonder, for us with a very small group with a very rare disease, does it behoove us to be actively working towards being included in the initial trials, or do we sit back and wait and see how things go, and then would our physicians, just be able to use that drug anyway on an ad hoc basis to treat our boys?
It's a good question. I do think that advocacy, so we actually did bring that up about, are there certain groups of individuals that the company could work with to maybe better understand the needs. And actually the Barth Syndrome Foundation was one group that came up during the discussion. I do think it's worthwhile. You have to remember, though, that the companies are doing what the FDA tells them to do. You know, there's nothing that they're not opposed necessarily to treating a lot of people with a broad bandwidth, but the FDA is going to dictate who they treat and what the endpoints are. Now, there are ideas, as you all know, there are treatment strategies that can achieve compassionate use, right? So you can lobby through local IRBs and the FDA to get use of a drug that is an off-label, unapproved indication, and that sometimes that can happen. And I do think that if Barth was not included in our initial inclusion study group for this Novartis, that those are the kind of opportunities to say we want access to the drug. We want access to the drug. How can we do it? And I think making these companies aware of that is always helpful. The providers, you know, at least myself and I think most of the people who are involved with Barth syndrome care would be very supportive of that idea. Recognizing, though, that the drug company, you know, they're not necessarily being bad or anything if they don't supply the drug. It's just that their hands are tied until it becomes FDA approved.
Sure. I'm just thinking,
but remember, though, for adults, once it gets approval in the United States, that's an off-label. I mean, that once it's approved, you know, for patients over 18 or however you define an adult, those patients should, in theory, have access to the drug. And I anticipate that happening probably in July or August, actually.
Okay, great. Thank you.
Well, I really appreciate your all's time, and thanks, as always, for the chance to talk to everyone.
We appreciate
yours. Thank you very much.
Your time, and we certainly we want to do this again. This was very good to just answer the questions because I think there's always more. So look at your calendar, please. Let's make
absolutely.
And this was wonderful, and I think everybody here is, you know, everybody's nodding their head, as you can see here, and I'm sure they are at home. Thank you, Dr. Jefferies. And Zaza, you're still on the call. We appreciate you for being here and staying through the duration. It was wonderful. And if the families would like to stay on after Dr. Jefferies is now that he's leaving, please feel free to do so, and we can have a little chit chat, you know, among the families, because we rarely have this opportunity.
Yeah, and thanks again. Please send any emails, and I look forward to hearing from everyone.
Thank you so much. Thank you.